Okay. All right, this is video 3 where we're going to talk about pharmacokinetic changes in clearance. And of course, changes in clearance are very important to be aware of. We already know that renal function declines from that earlier slide we just saw. Um, so we're going to talk about hepatic clearance first and then renal clearance. Obviously, with hepatic clearance, we're worried about these 3 different components: intrinsic clearance or hepatic enzyme activity, hepatic blood flow for Q, and plasma protein binding. So we already know that enzyme activity can be changed by age. We know that blood flows can be changed by age. And we know that albumin and AAG can change with age. So we know we have some setups for some alteration. So liver blood flow decreases 40% from the age of 25 to 65 years of age, can also be affected by congestive heart failure, which is a common problem as we age. The cytochrome P450 enzymes, both in the gut and the liver, the activity will decline with age. There's about a 1% decline in activity with each year you live. So it's each trip around the sun or with each birthday candle, you're losing about 1% of your enzyme activity. There's also a loss in your ability to induce enzymes. Remember, induction of enzymes means that you're making more enzyme. So your ability to do that, because that takes protein and a lot of other resources in the body, your ability to do that as you age also decreases. Not so much with inhibition. Inhibition is usually competition that's not affected by age, other than you may be on more drugs and therefore may be more prone to it. But the actual ability to inhibit is usually not affected by age, only the ability to induce enzymes. And phase 2 enzymes seem to be unaffected by age, whereas our P450 phase 1 enzymes are. So we want to look to our lot benzodiazepines, lorazepam, oxazepam, and temazepam, because we avoid some of these enzyme systems. Sorry for the quality of this picture, but this shows the influence of age and sex on the clearance of cytochrome P453A substrates. You can see there's a lot more variability in, let's see, so this is males, females, and if we clump everybody together. So this is the ratio of mean clearance in the elderly versus the young. So if it stayed the same, it would be 1. So here's our 1, right? So these people, there is no change. This person, it actually improved. Actually, their enzyme activity increased with age, but you can see that's an outlier. So if it were to stay the same, it would be 1. And as this gets smaller, there's more of a decline in the elderly's clearance of P453A substrates. So we can see the average is a little over 0.6 for both males and females, but there's a lot more variability in the female population than in the male population. And if you don't separate by gender, it actually is increased a little bit, but that's probably just by the numbers. I don't know why that would be, but it's about 60%. And we don't have the information here about what means elderly, what is the definition of elderly versus the definition of young. But in general, not surprisingly, the P450 substrate metabolism decreases with age. Diazepam half-life with age. Again, diazepam, it has a half-life, or the half-life is dependent upon volume and clearance. If clearance declines, your half-life is going to go up. So we can see we would expect the half-life to go up. And here's at the age 20, you can see the average is about a 40-hour half-life. And when you get to 60 to 80, it's more than doubled, about doubled. Your half-life doubles. So clearance is maybe in half. There could also be some changes in volume, but we can clearly see that there's an extension of half-life, which is why we want to avoid, one of the reasons we want to avoid diazepam in these patients. Here's diazepam with taking away the consideration of binding. the clearance. Again, young, here we have some more data versus older. And we can see, and then they also separate these out by male and female. We can see that the clearance declines in the male, declines in the female. And actually the female elderly is about the same as the male. So they're quite different depending upon the gender of the patient. All right, here's also estimated warfarin dose. So again, if your intrinsic clearance is decreasing with age, and the warfarin is a low extraction drug, so you'd expect the clearance to decrease. Therefore, you're going to need less drug to have the same effect. So you can see as we age, here's 45 is where we started, and we're ending up at 85. Males and females, males, females, males, females. So this is different types of mutations. In all cases, there is a decrease in the dose needed, the estimated daily dose needed, because clearance is declining. How about on renal clearance? By the way, well, we didn't talk about any high extraction drugs in the last, but remember, liver blood flow decreases by 40% between the ages of 25 and 65. So we can see that, and that's what determines the clearance for those high extraction drugs, right? How about renal clearance? There's a decrease in renal tubular function as we age. There's also a decrease, basically a decrease in all blood flows, usually due somewhat to CHF, but also just due to aging. So there's a decrease in perfusion of the kidneys, decrease in renal flow, decrease in GFR, and therefore creatinine clearance decreases with age. You lose about 1% per year again. But there's a lot of variability in renal function. A lot of it has to do with other disease states, like do they have diabetes? Do they have other renal impairment issues? Also, due to sarcopenia, there may be a falsely low serum creatinine. In other words, remember, serum creatinine is the measure of the breakdown of muscle. As we age, the muscle decreases, and patients with sarcopenia don't have much muscle to break down. Therefore, their serum creatinine could be falsely low, which implies that you're doing a good job clearing the creatinine. But if you're not making it in the way that others are, you can't really, it becomes a false elevation of creatinine clearance. So it will overestimate the renal function if you're using Cockcroft-Gault to estimate creatinine clearance, which is what we commonly use. So that sarcopenia really can throw a wrench into the reliability of the Cockcroft-Gault. So again, creatinine excretion decreases with age. Serum creatinine could stay the same, again, because of that loss of muscle mass. So you can't be tricked by this. All right, I'll go over this on the next video. Thanks.